Welcome to the Sage Women podcast, hosted by Melanie White and Dr. Nick Engera. We have real conversations with real women, health professionals, and coaches who share stories about perimenopause, menopause, and a range of women's health issues. Please subscribe so you get the latest updates every fortnight.
It's Melanie White here on the Sage Women podcast, and I'm so pleased to have Jayashri Kulkarni here today, who is the founder and director of two research centres, the Her Centre Australia and Monash's Alfred Psychiatry Research Centre. She's the head of the Department of Psychiatry, Clinical Central School and the Faculty of Medicine, Nursing and Health Sciences, and the head of Women's Mental Health at Cabrini Health. That's a lot of things that you do, Jayashri.
As you read it out, I'm thinking, no wonder I feel tired. Nice to chat to you today, Melanie. Thank you for inviting me.
I'm so thrilled that you've made the time. You're an international leader in the space of women's hormones and the link with mental health. Your work is groundbreaking and well known. And how did you get here? How did you choose this career path?
I'm still not sure where here is, but I have a passion, obviously, about women's mental health. And I think that started from patients that I'd seen way back. As a junior registrar. I was really quite appalled at the lack of sensitivity and the lack of great outcomes for women with, at that time it was women with schizophrenia, but women with depression and so on. And so that really piqued my interest, was the women, and them saying things like, I've told so many people that it's my hormones, doc, and no one's listening. So that really got me thinking about what is the relationship between hormones and mental health. And for a long time, there was not that much that was happening. In fact, I think some of the biggest articles that I started seeing were in the 1990s, and they were animal studies, but again, clinical translation hadn't happened. So it was all very much in the embryonic stage, and I feel very fortunate that I met a lot of great people along the way, including the women, who I think are amazing in that some of the outcomes that women with severe mental illness manage to achieve. So their words really stuck with me, as well as I met colleagues who along the way first looked bemused at my ideas of thinking about hormones and mental health, and then kind of, okay, well, if that's what you want to do, we'll help. And so over time, of course, the area has grown a bit, but I'm still frustrated that we haven't got to a place that I think, okay, this is where I want to be. So when you said, how did you get here? I don't see how do I get here. I see like, where is the next bit and how do we get to the next bit? And the next bit that I'm clear that I want to try and influence is getting the use of hormone treatments more readily accepted by women themselves who have mental health issues that are related to hormone disturbances, and in particular to get my psychiatry colleagues to utilise hormone treatments in their clinical practices. That's just a couple. The other third thing that I'm very clear that we need to do something better about is understanding the role that trauma has to play in the production of mental ill health, and then deal with that in a much better person-centric way that benefits everyone. And of course, along the way, there'll be other, things that I'll suddenly think, oh, that's really interesting, and then have to sort of drag myself back to the main frame. But women's mental health in general, and this is the part that I am excited about, because I do think that in the last 5 years, particularly coming out of COVID, I actually think there is a little bit more interest in women's health, of which, of course, mental health is a critical element. So that's a very long, rambling answer to how do I get here, but it's more about where do you
want to go? Yeah. And that's a complex interplay, isn't it, between hormones and mental health, psychosocial factors. There's a whole lot of things that are going to open up from this conversation that's being started right now.
Yeah, it's interesting, isn't it? I mean, I actually I'm not really sure how this happened, but I'm very pleased that it is happening. I think perhaps it might have been that COVID kind of really blew apart the systems that were failing, or that people were just kind of sticking a finger in the dam to keep it from exploding, and all of a sudden it did explode. And so now you've got to rethink, how are you going to help? And in particular, women's mental health was really affected. Globally, there are statistics and survey data that show that women, in fact, experienced loss of income from casual labour, jobs disappeared, having to then work from home, and all of the bits that entailed, having to educate children at home, often became very much a single female focus. The difficulties of caring for elderly people when threatened with COVID virus, and having to cope with lockdown, like being in Melbourne, we were locked down a lot. And then the women who actually experienced domestic violence, and then being locked in with the perpetrator of the violence, and that raised enormous issues. So every way you look, there were a lot of things that women had to cope with, some did cope with, and I think that's why we're having the discussion about what can we do.
Absolutely. It was the ultimate global stress test, wasn't it? Let's thrust a pandemic on everyone, and global lockdowns, and that long-term uncertainty that we all faced. And from the coaching perspective and the work that we do at Sage, we really saw a lot of people saying, oh, I'm not able to do the things I usually do, throwing everything up in the air to be questioned. What really is important to me? And what am I struggling with right now that I need to fix? And we actually saw a huge shift in people really starting to focus on their own health and well-being, and to understand the drivers in their lives for what's working and what's not.
Absolutely.
Yeah.
So here we are, lots to do.
And we've talked about some of the challenges that women have faced in the last couple of years. Also, I think we've had the Boland report and the review of the psychosocial landscape as well. But coming back to menopause and the 34 odd symptoms that we see, what are the challenges that women face that you see most often?
Oh, look, I think this is one of the biggest challenges for women in the workforce. And we continually see at all different types of workplaces that women in their midlife, beginning in the mid-40s, will experience menopause symptoms beginning in the brain first, and being the most difficult to, in fact, overcome. And that will lead to a premature departure from the workplace, or if not an absolute, quitting the job, taking a step back, or not actually taking steps forward in terms of seniority. And I've heard this time and time and time again, and I've seen and been involved in presentations right across the spectrum, from factory floors to hospitals to super specialists, in medicine, who are women who say they just can't deal with all of the stuff that they're dealing with. And the tipping factor is brain fog, anxiety, and depression that some women, not all women, but some women experience when they hit the mid-40s as a perimenopause or early menopause symptom. And brain fog in particular is something that really confuses people. Like, I've heard stories from women who say things like, I was fine, and then I woke up and I couldn't remember my phone number. I couldn't remember, I went shopping and I couldn't remember where I parked my car, or I'm in the workplace and all of a sudden I couldn't work out how to turn on my computer or to do things that I've done several thousand times before. And then the panic sets in about what's going on. Am I going to be sacked? Are people talking about me behind my back that I'm no good at my job? I'm old. This is mid-40s. And people saying things like, I sat in the training program for a new computer program at work and everybody else got it and I'm still sitting there trying to work out how to do this, and I'm sure they're all laughing at me thinking, you know, she's an old dog, you can't teach her new tricks, and all these self-esteem doubting issues come into play if you are not in charge of your cognitive processes, or if you sense that there's a decline in cognitive processes. And then there's the question that I've been asked many, many times, am I dementing? Do I have early onset Alzheimer's, particularly in people who've got a family history of a family member who has Alzheimer's? So that's brain fog. And it can come on suddenly, and it can come on about all different areas. And
you're telling my story.
It doesn't matter who you are. You know, I've met CEOs of you know, very, very successful businesses, and you know, the poor woman was telling me the story about how she just froze in a board meeting. You know, she's a CEO of this magnificent company, and she just froze. And she said, you know, people were looking at her, she was looking back, and it was like, she said, it was like suddenly her whole brain just went empty.
Yeah.
And it had never happened before. I met a comedian whose job it is to get on stage and, you know, do the quick routine.
Yeah.
And all of a sudden, with brain fog, she was experiencing what we call the tip of the tongue. What's that word? What is it? What is it? You know, and so for her, in her job, that was a disaster, because her whole job was about being funny and presenting and being loud and extroverted and moving from one thing to another quickly, which she had done. And then all of a sudden she panicked on stage, and then that set up a panic cycle. And once somebody starts to get really anxious, they fear the fear. So there's a fear of then having a panic attack in public, and that becomes then its own vicious thing. So there's a couple of examples from very diverse areas. I've spoken to anaesthetists, you know, very leading anaesthetists, women anaesthetists, who said, I had to take a step back from being in a super specialist surgical area in a big teaching hospital because I just, irritability is the other part of this. Her word, I couldn't take the crap from surgeons anymore. And she said she just lost her, you know, like she had a very short fuse, but also she said things like, you know, I was having to think and rethink drug dosages, and, you know, that she said she checked and double checked things, but it was slowing her down in routines, which she had been very well practiced in. And worse, she said that she felt observed by the surgeon, by the nursing staff, by the students, by the, you know, assistant registrar in anesthetics and all the rest of it. So, you know, again, she took a step out of it. And this is someone who had done this beautifully and continued to do it beautifully, but her fear meant that we lost that person to the complex workforce, you know, and we can't afford this. Nurse after nurse after nurse I saw during the height of the pandemic drop out of the workforce in their mid-40s or early 50s. And it was the X factor, the tipping factor was that, A, they were stressed at work, but they were not sleeping. They had memory brain fog challenges, and they were very worried that they would do something that would be a terrible mistake. And then they had anxiety and panic, which they were self-medicating with alcohol.
Which just makes things worse. It's
terrible. It's terrible. But, you know, we have several people have reported the rise in alcohol consumption in women in midlife. And we all kind of laugh about it and sort of, oh, yes, you know, it's just wine. But I've seen women who it wasn't their practice to drink a bottle, which then got to 2 bottles of wine, because of the anxiety, and they were trying to treat it themselves without really anybody helping to understand what's behind this. Depression then sets in. So this is a different sort of presentation of depression in menopausal, perimenopausal. Perimenopause is the early menopause. And it's hard to pick up because she'll say, well, you know, I don't think there's anything else that's particularly new. I've always juggled my adolescent children, my relationship, my elderly parents, my workplace. These are normal. I mean, there are stresses in all of these, true. But I've handled this. That's my life. And then all of a sudden, it's as if all the balls that she's been juggling just drop. And that's when I think we need to think and talk about what is the X factor that has taken this very busy but very competent woman from being able to handle all of those stresses to suddenly not handling them. It's not, and it's often very, very much like that. It's sudden and it's fluctuating as well. And that makes it tricky to diagnose because there's no blood tests that will diagnose this. There's no way we can get to see what's happening in the brain when blood tests of the body won't tell us that.
And in terms of anxiety and depression in menopause, what percentage of women are we talking about here?
The surveys, I wish we'd stop doing surveys in some way because the epidemiology is not helping us in any of this debate.
Yeah.
So the surveys go from somewhere between 20% to 60%. So it depends. It depends, great, take your pick. It depends on what do you include. If you include a completely disabling mental illness so that you've got severe anxiety with panic, including things like agoraphobia, people can't get out of the house, or just panic upon panic attacks with the full heart beating rapidly, jelly legs, hyperventilating, seeing spots, thinking you're going to pass out. That's a panic attack. And some people really say, well, you have to have 4 of them before you can include, et cetera, et cetera. So depending on where you draw that line, you'll get the numbers. But the issue, I think, is even if you took the minimum, which is 20%, most people would say 20% of women going through menopause have something. That's 1 in 5 women, and that's not a small number.
That's significant.
And I think that's the actual smallest number. I think there's a lot more because the fluctuation's different as well. So, sometimes people have the most dire panic, anxiety, brain fog, can't function for about a week, and then all of a sudden the following week she'll wake up and go, oh, I feel fine now. And then it's like, well, what happened? What was that? That makes it difficult for her to understand. But it also makes it difficult for the family to understand or friends because it's like, was she putting that on? What was going on there? Or worse is that some genius diagnoses this as bipolar disorder. And then she gets into the merry-go-round of, this medication, that one causes side effects, this one causes weight gain, and so on and so on. And that's difficult to peel back. So we're in a bind because we don't have that perfect test. But what we do have is we have the voice of the woman who at 46 or 47 is pretty good at knowing what's a stress in her environment and her world and what's something that's changed inside her. And that's what I think we need to empower women to go, hey, listen to me. I know me, and this is new. This is not just the workplace getting more hectic or the relationship being difficult. I know what that feels like. This is different. So if we listen, we might be able to get a lot further.
And it would be so easy if menopause onset was characterized by your hand turning bright blue, because then we'd all know, right? And the conversation we hear is that women say retrospectively, I was probably entering perimenopause 5 years ago.
That's the point. It's the retrospective knowledge and then the retrospective diagnosis by medical teams. Because once the hot flushes hit and once the periods stop, then it's very obvious. Then it all falls into place. But, there's a lot of damage that can have happened if she's had a disabling mental health problem for the last 8 years. And menopause is about an 8 to 12 year process. So we're also dealing with something that isn't, I'll just grin and bear it, it'll go away, it'll get better.
It disrupts daily life.
Yes.
Yeah. What might be some of those early warning signs for someone that maybe picks up something's wrong in her body, in her mind, and thinks, oh, it's probably just a bad day, or, oh, I wonder what this is, but perhaps isn't seeking help? What might that person be looking for to know that this is something they need to go and see a health professional about?
So I think in terms of the mental health pickup, it would be the anxiety. So this is a different form of mental health. We call it menopausal depression, but it's a different form because the anxiety symptoms present pretty early. And I would suggest for women to look at anxiety that occurs with tasks that they normally do. It's not, like if you suddenly ask somebody to go and give a speech, in front of 1,000 people and they're not used to speaking publicly, that will make anyone anxious. But I'm talking about the example of the CEO who's presented to her board numerous occasions, and yet on this occasion she panicked, and there wasn't even a particular, like it wasn't that the company was going under or, like a particular new thing. So look for anxiety where you're in normal situations that wouldn't cause an anxiety or panic reaction. That's one thing. The second thing is the irritability and hostility. Yes, I know we can all have annoying, like why can't the kids just get those socks out of the lounge room and put them in the laundry basket and all that sort of stuff.
Yeah.
You know about that. But it's when that fuse is really short that you find yourself snapping at situations that are not typical for you, or trusted family and friends are saying, you're really grouchy or grumpy, or what's going on. That irritability and hostility, which may be unusual for you, is something else to be mindful of. So anxiety, irritability, hostility, tiredness. So for those who've had children, they remember what it felt like in the first trimester, being just exhausted.
Yeah.
And there can be a measure of that as well. And this can be despite not having any reason to be completely exhausted, but that continual, like I had one lady who said, I can't even brush my hair. I don't have the energy to pick my hairbrush up and brush my hair. So it's that bone weariness that people experience. Change in sleep pattern is another sensitive indicator. So these are the early sensitive indicators. They're not the usual. As you can see, the usual depression is somebody feels sad, they feel tearful. There might be tears, but it's not quite the same quality of I feel sad and depressed. And it's a different quality. So I would say look for those things. I have developed what we call the Meno-D, which is a menopause depression questionnaire. And it puts questions in different boxes in the sense of different body symptoms, different brain symptoms. And so I'm very keen for women to look at it themselves because, it's a self-check. I'd say it'd be really unusual for someone to go and seek medical advice at the early stages. I reckon most women hang on and hang on and hang on until there's a critical incident. And the critical incident could be something goes terribly wrong at work, or the irritability, hostility plays out in the relationship side of things, either with children or with romantic partner or with others, that somebody then says, what is wrong with you? And might start off in quite a nasty way, but, at least that might then steer towards trying to work out what's going on.
There really is a need for a self-awareness and an understanding of what the early symptoms of mental health issues in menopause could be so that someone can self-identify. And your test sounds amazing as a tool for that.
Yeah. That's on our website, but also I think the other side of it is trusting your gut as well. And I often have, that conversation with many women who come to my clinic who say, well, I picked this up 5 years ago, but no one was listening to me. And so when I went to speak to my primary healthcare practitioner or other healthcare practitioners, they would go, oh, but, you know, you poor thing, you've got so much work, you've got, you know, your relationship clearly is difficult, and so then in comes the psychological work, which can be just helpful, but you know, it's not getting to the solution for those ladies, for those patients who have been very clear that they knew what work stress felt like, and they knew what relationship stress feels like. They've dealt with that before. It's not like this is brand new.
Yeah.
But they will often not back themselves. And that's another thing we've got to engender is confidence, self-confidence, that if you think there is something wrong, stick with it, because, you know, hopefully we can get better attention for you if you're confident as to what you think is going on.
And confident that you'll be heard and acknowledged and treated with respect.
Yes.
Yeah.
Invalidation is another whole area. And again, at this stage, one of the mental health issues is lowering of self-esteem. And the self-esteem might be bad to start with, and then it just takes an even greater plummet. And there's a lot of negative self-talk. I'm big, I'm fat, I'm ugly, I'm old, I'm useless, etc., etc. And so when somebody says, oh, you know, you think it's this, but it's not really. And so that can really then be quite invalidating. So that's important. Or the worst thing is the GP will say, I've done a blood test and look, it's all fine, it's all good. So you're wrong. So you know, there's a lot it's difficult to withstand, but it is important to keep being heard. And I think that's the other thing that we're seeing in what's going on in our communities in the last few years is there's a greater, well, maybe the women's voice is getting louder.
And a few women speaking up on behalf of others and advocating to raise the issue, to give people a voice who might not ordinarily speak up. Too.
Yes. So now we need to deal with the other side, which is to get the healthcare and other professionals to listen. So, yeah, both sides need attention.
Well, we still have probably come a long way from the 60s. I know my mother was put on Valium for several years. And it seems to be that was the thing of the day, to put women on Valium.
Oh, dear. Yes. What was that other thing? The Bex and the Good Lie Down? Or
something. Let's not get on that soapbox. I'm keen to change tack a little bit, Jayashri, and talk about maybe some of the most interesting points from your research so far.
So we're doing research in women's mental health broadly, and there are different areas that I'm tackling. And I would say the kind of three broad areas. One is the hormones and mental health. And so menopause is obviously a big area, but we're also working in premenstrual depression, which is another poorly understood condition that fluctuates cyclically with the menstrual cycle. So we have women who are really significantly, despairingly depressed for 10 to 14 days, and then they quickly bounce back in the other 14 or more days, and it looks very cyclical, and so they get labelled bipolar and on with all these medications, whereas in fact it is a hormonal response. Some women are just more sensitive to hormone fluctuations in terms of their brain responses than developing depression, anxiety, or trauma responses and so on. So that PMDD research is again a similar sort of thing, raise the awareness that this is menstrual cycle related, take the story, then think about using a hormone strategy. And in the PMDD women, it's quite a simple strategy. It's the pill. So but make sure you use a pill that isn't going to make the depression worse, because there are some of those around, which then led us into the pill research. So we've got our particular trials that looked at what is the best pill to use, what are the worst ones to use in terms of depression, because many of the pill manufacturers didn't test for depression when they were testing the validity and the reliability of their pill. They looked at contraceptive capacity, which is the first reason for this, but then there are side effects that were not really picked up. So there are pills on the market which create depression in some women, the sensitive women.
Wow.
So that's another area of work. And then, of course, the menopause work, we're doing clinical trials looking at the use of different hormone therapies for women who have this type of menopausal depression, anxiety, brain fog. So there's hormone work there. That led me to, when I'm talking with my patients in the clinic, we spend a long time in the secondary consultation because this is a specialist, super specialist clinic in the sense that they're often referred by other specialists. We spend about 2 hours with each woman.
Wow.
So we go through everything, and including early life. And so it just struck me a long time ago that, we were underestimating the level of emotional or physical or sexual trauma abuse in many of our women who were presenting with something else. They had just kind of pushed the trauma aside. So then I started looking at the effects of early life trauma in girls on the brain and what happens as these girls grow up. I mean, obviously we're looking at retrospective stories from our parents. But there's definitely a link, and the link is probably related to the stress in early life. Stress is a bit of a weak word, but, the traumas and things that happen actually impact biologically in the brain by shifting the brain hormone sensitivities as well as the brain chemistry. And so you have a different picture of depression and anxiety, and sort of like a post-traumatic stress disorder syndrome that many women experience. So that's another area. So there's some hormone work. We're also doing work looking at challenging the diagnoses that don't help women. So there is this diagnosis that I've got in my sights to see if we can get rid of, which is borderline personality disorder.
Oh, yeah.
Now, many people have heard of that, but it's particularly the label that is given to women young women who present with deliberate self-harm. And so these are the women who present to emergency departments, for example, having cut their wrists or taken overdoses. And somehow, over decades and decades, we've managed to call this a personality disorder. And that then, I think, is like blaming the victim. Go back and you look through the story of the young women, and yes, young men can have this too, but predominantly it's young women who get the borderline label. There is often a horrible story of early life trauma and stress. And I include in that emotional invalidation. So, that brings into play a whole lot of stresses that probably were not considered to be stressful in years gone by, but they are very stressful. Young girls' brains are more vulnerable to the environmental factors than young boys' brains. That's a generalization, but it tends to be true. And so we cannot underestimate the impact that a girl experiences in a brain biology sense of continually being belittled or very strict parenting or negative, harsh comments and so on. So there's that, also physical punishments and abuse, and then, of course, the awful sexual abuse. And in these women who've presented with self-harm, there is often that story, but it gets missed because in the hurly-burly of emergency departments or in psych wards and so on, there's almost a tendency to just deal with the tip of the iceberg. And
crisis at the time and not the whole person.
Yes.
Yeah.
And so it's easier to then come out with this label, borderline personality disorder, which is a stupid term, no matter which way you look at it. I mean, personality disorder is disgraceful.
But what's borderline?
And then borderline is the other thing. Like people have said, well, I got diagnosed as borderline. What does that mean? Do I have something or do I not have something? Can you make up your minds? It's a stupid term. I mean, it's a very old analytical term, psychoanalytical term, that meant borderline psychosis and other. But, that's just really old. And it is not just old-fashioned and therefore quaint. It's old and damaging, because what I often see is that these young women, as they've got older, are actually incredibly resilient for even existing and surviving some of the horror stories that you hear about what's going on, in what went on and what goes on. And so instead of playing to their strengths, instead of lifting them up, this diagnosis tends to put them down and make out that they're somehow flawed. And if you tell someone that their personality is disordered, that's the essence of who they are.
Their identity,
yeah,
in a way.
So you've got nowhere to move, and I just think that's been an absolute disgrace. So, yes, so that's another mission, because it is actually a trauma disorder. So when you take the whole story, here's someone who's had trauma, and their maladaptive response to the trauma is the self-harm and the other things. But if you understand it and work alongside the individual, sit next to her and spend the time and then get a better feel, you can actually employ trauma therapies, of which there are some good ones. And again, you're doing this collaborative work which enhances her skills and her resilience, which is really what she's going to need to get through the next episode of bullying or whatever's going on. So that is another whole thing. And then the third area of research is service delivery research. So I don't know if your listeners would know about how psychiatry wards in general are structured in most Western countries, apart from the UK. But in the US and here in New Zealand and across Europe, men and women are managed together on inpatient units, inpatient psychiatry units. So this has created a lot of issues. And in my time as junior registrar, a senior registrar, and then as a consultant, I unfortunately saw and had to handle awful situations of sexual abuse of the women inpatients when they came for help, because they're managed side by side in the same ward with men who are disinhibited because they have psychotic illnesses, but they're disinhibited more now by the amphetamine substance misuse of things that are out there on the street. They're very activating and disinhibiting. So you throw that in. And plus also with the advent of community psychiatry, anyone who can be managed out of hospital is. So now you've got the sickest of the sick in the inpatient unit, and everybody's managed together. And so there just was awful stories. So again, one of my missions was to see if we could get gender segregated wards. Now, that's a whole saga of
becoming complicated.
Of trying to get funding, trying to get capital works, trying to get all sorts of change in policies and at governmental levels and so on. And I didn't manage to get that far in the public system. I did manage to get the first ever women's only wing, and then that became a thing that most public hospitals had women's only wings, some with more success than others. But I'm delighted that in 2020, I managed to convince the CEO of a private hospital, Cabrini Health, to have a women's only hospital. And she, the CEO of the whole thing, Sue Williams, was wonderful. And within just a few minutes of pitching the idea, she was on board. And so it moved fast. And then within about 8 months, I got to design a ward, I got to design the program, and we opened the first ever women's mental health hospital in Australia in September 2021. So that's at Cabrini Health. And now, interestingly, there are other women's only or women's mental health facilities that are opening up around Melbourne and one in Sydney. Sorry, two. One's open in Sydney, another one planned in Queensland, and I was just over in the West talking with our colleagues over there. So it is catching up, and it's just common sense. This is about safety, it's about privacy, and it's really a ridiculous situation that should never have been allowed to get to this point. That's why, I mean, it's another campaign that is in service delivery, but it's all, the thread that goes through it all is women's mental health. But lots to do.
You're busy. And before we finish today, I'd love to, you've talked a bit about what we need to do. Is there something you could say to the women listening to this, whether they're individual women or women working in organisations, about where we need to go with women's health, menopause and mental health?
I really find that the biggest thing that's holding us back is funding for research. Now, if I can be so bold as to be blunt, funding organisations are still predominantly male, run by males. And the focus on women's mental health is right at the bottom of the barrel. It's really, even though we're talking about it's got better in the last 5 years, it's still not a priority. Because it's big and it's vague and it's women and it's, everyone has a viewpoint, and so that makes it difficult. But what we need right now for menopause mental health is we need proper funding to run a clinical trial to compare the efficacy of hormone treatment versus standard antidepressant treatment, because today the guidelines around the world say you can't use hormone therapy as a treatment for depression or anxiety in the menopause. That's not seen as the treatment of choice. The treatment of choice is antidepressant after antidepressant, and we know that they don't work. But what has happened is they go, well, where's your clinical trial evidence? Yeah. We can't do the clinical trial because when we go to the funders, they go, there's no such thing as menopause depression. It's not in any of the books. Well, it's not in any of the books because we don't have the clinical evidence. So you can see this ridiculous catch-22.
Yeah, women are understudied generally throughout the history of medicine.
Yes. So that is something that we're really struggling with, is the routine funding for research does not particularly, or no, it isn't helping mental health. It's just a tricky thing to try and get the funding. And we need the funding to get the evidence. The evidence then gets put into guidelines, and then that will be a real step forward, because practitioners of every sort can then go, oh, look, here's the guideline. Oh, yes, you say you have this. Okay, you can use hormones.
It's a watershed moment, really, that you're working towards.
Yep, I am. And I think it's really good to have the backing of women with the lived experience of menopause depression who are happy to speak out. So I would urge the women out there that if you have menopause depression, speak out, get yourself some hormone therapy if that's what you think you need, and then speak out again once you're better, because your words, your knowledge and your wisdom, as always, but at this very critical point, will actually help to shift the field forward. So we can't do the shush, don't talk about this secret women stuff. It's not. We've got to get past that. So I would really urge women out there to have self-determination, self-knowledge of their own health and mental health, self-confidence, that if they think it is about the menopause, then stick with your gut instinct, because you're right. You know what's going on. And then the third thing is speak up about menopause mental health in anywhere that you can. Don't just keep it to women's conversations. Speak about it to your male family, friends, colleagues, because it's everyone's business. Women's mental health is everyone's business, and we need to make it a priority, not just nationally, but globally as well.
Absolutely agreed, Jayashri. Your work sounds phenomenal. I'm thinking, gee, you need 10 lifetimes to do everything that you've done so far, let alone what you're going to do. I'm so privileged to have you on the podcast today, and thank you very much for the time, for sharing your knowledge and wisdom and expertise, and for the parting tips, because that really gives us a direction as where do we need to go as organisations to move the needle. And you've just pointed out some really important things that we can all participate in. So thanks so much.
Thanks, Melanie. Lovely to meet you.